Hello and welcome to my presentation. My name is Esmond Wong and I'm a pharmacist and diabetes educator practicing in Calgary, and I'm very excited to upload this video. I've been doing these presentations for probably about 8 years now, and I've probably helped around 500 people pass their CDE exam. And I've recorded these presentations before, but I had complaints that there was a lot of restaurant noise and there was just too much background noise so that people couldn't hear. So I'm just re-recording these videos at my home. This is meant to be a casual presentation. Please don't mind me as I sip on my tea. And this is a re-recording of a presentation that I did on February 11th. That program was sponsored by BD and Sanofi. So if you've watched last year's videos, there probably isn't much new content in these videos, but the sound will be better and you may pick up some new tips. Again, if you want more information, please visit my website, which is www.cdestudycourse.com. So let's begin with the presentation. Here are my disclosure slides. As you can see, I've spoken for a number of pharma companies, probably all the ones related to diabetes. So here are program objectives. So first I want to review the structure of the CDE exam and the competencies lists that you'll find in the appendix of the CDE-CB handbook that you should have gotten. I wanted to also compare normal glucose metabolism with abnormal glucose metabolism. You need to understand what's normal before you can see what's abnormal about it. And I want to briefly just review some of the pharmacokinetics and safety of some newer insulins and review how injections can affect glycemic control. Okay, so the exam. So for the exam, there are 165 questions. It's all multiple choice. There are no short answer or essay type questions. The deadline to apply was February 1st, and if you have not applied by then you cannot write this year. You must apply by February 1st before you can write, and the exam is only once a year. So the exam is 165 multiple choice questions. You have 3.5 hours or 210 minutes. So that means roughly you have about 1.25 minutes or 75 seconds per question. Now it's also important to note that of the 165 questions, there are 25 pilot questions, which are kind of like questions that the exam makers are making up and testing to see if they're fair. But those pilot questions aren't worth any marks. So, and you don't know which question is a pilot question or a real question. So of the 165 questions on the exam, only 140 will help you actually pass the exam. Only those ones are worth marks. So for example, one year, I got this ridiculous question about medical alert bracelets. I got a question asking, how much they cost, and if you called their emergency number, how long was the delay to get to you? Just completely something out of the blue. I didn't realize, when I was studying this, I never came across anything like this. And after the exam, I was talking with my friends, and same thing, they got this really weird question, and nobody had any idea what the right answer was. So, and then the year following, I asked my students, did you come across a question on medical alert bracelets? And they said no. And so that must have been a pilot question that was not worth any marks. Again, the pilot questions, they're not differentiated from the real questions. So you don't know if a question question you're doing is actually a pilot question or just a normal question, okay? Now, the unfortunate part was one of my friends who owns his own pharmacy and sells medical alert bracelets got really hung up on this question. He sells them and he was like, damn it, I should really know the answer to this question. So he spent like about 10 minutes trying to figure out this one question, which is a real big waste of time because he spent that 10 minutes on a question that was worth 0 marks. And remember, time is your most important resource on the exam. So you only have 75 seconds per question. So if you spend 10 minutes on a question that doesn't even give you marks, that's a big deal. That's like 5%, giving yourself a 5% time penalty. And you just don't want to do that. Let me see what else here. Yes, and a lot of the times on exam, there'll be questions where, you know, in real life, I would never do any of those answers. Like you're given A, you're given B, you're given C, and you're giving D. And in real life, you know, I would never choose any of those ones. I would make up my own question, make up my own answer and put as E. But unfortunately on exam, you can't do that. You can't write in answers or anything like that. It's purely multiple choice. You have to make a decision and you don't get to write in any input. So it can be frustrating if one of the answers that is on the exam is not something that you would do in real life. Uh, in that case, just try to pick the best available one and don't get upset. There was this one year, there was this pediatrics question. And there was one nurse who works in the DIP clinic, the Diabetes and Pregnancy Clinic here in Calgary. And none of the answers really satisfied her. And she got really upset and outraged. She's very passionate and she's, of course, a specialist in diabetes and pregnancy. And so she got really upset and she kind of, on just the side, she wrote this like big paragraph about how none of these answers are correct, this exam is not up to date, and how she was really frustrated how she couldn't put a right answer. And she probably spent about 15 minutes writing this big essay on why each question is wrong and why the right answer should be X, which wasn't on the exam. And you know, the terrible thing is that question didn't show up the next year. So it was a test question. So she got all upset and spent 15 minutes of precious time complaining about a question that was worth 0 marks. So, you know, if you encounter a question where you don't know the answer or you get frustrated with it, stop and take 4 deep breaths. 4 because, you know, under 4, it's like hypoglycemia. That's how I kind of teach my students. But take 4 deep breaths, relax, and just go on to the next question. It might be a pilot question that was worth 0 marks anyway, so don't spend too much time on it. Also note that in the exam, there are different versions of the exam. They all have the same questions, but the order is scrambled. So if after the exam you say, hey, hey buddy, what did you get for question 5? Oh, I got D. Oh, geez, I got C or something like that. That's not going to work. All the questions, the questions themselves are exactly the same, but the order of them is scrambled. There's like 5 different versions running around to prevent cheating. So, you know, so different people will have different answers for all the questions. Okay, let me just make sure I didn't miss anything. Okay, good. Okay, so exam structure. So each of the questions will test one of the three areas. Knowledge are straight, do you know it, or not questions. It's like, what's the mechanism of action of metformin, or what's the mechanism of action for SGLT2 inhibitors? Application questions are, you know, how do you adjust this person's diet, or how do you adjust this person's insulin, or what's wrong with this, what is this, you know, here's a patient scenario, what's he doing wrong that's causing hypoglycemia? They give you information, and then you have to apply knowledge to figure out the answer. Critical thinking questions require you to look at the situation from a healthcare provider and kind of like a higher level kind of thinking. For example, if a person's A1C is high, but they appear suicidally depressed, then discussing fiber isn't the priority. It's dealing with the suicidal depression. So those critical thinking questions are kind of like out of the box empathy questions. So if you look at your exam booklet, you can find it on www.cdecb.com to download these and look at the appendix. You'll find the competencies and how many questions of each are on the exam. As you can see, that there's a competencies, and then in each competency, there's different topics with different weights. So there's 1A, 2A, 1B, and 2B. So 1A is the ones that are is the most important. Those are the ones that will have the most questions. And 2B has the least. So for studying, if you want to be efficient, you should try to study most on 1A and 2A topics, and spend less time on 2A and 2B ones, because there will be less questions on them. So if you add all the numbers here, the 56, the 42, the 28, and the 14, that equals 140. And those 140 are the questions that are worth enough marks that will help you pass the exam. That are 25 are pilot questions, which takes up the total to 165. So this is what we're going to cover today. I'm going to cover a bit of pathophysiology and these two competencies. Okay. So another couple of things to note. You must bring your ID. I had a coworker a colleague at my work. She caught a ride with another person who was writing the exam, but she didn't bring her ID. She carpooled. And when she showed up, the invigilator would not let her write the exam because she couldn't verify if this person was the person she said she was. And so the invigilator had to, like, the exam started, and then my colleague was not allowed to start. The local Calgary invigilator had to call the invigilator in Ontario, and they had to have all this discussion, and then she had to sign this waiver to verify that she was the person whom she claimed to be. She had to had her photograph taken multiple times. And so as she started the exam late, probably about half an hour late, and think about how jarring that experience is. You don't want to start your exam with all this stress and stuff like that. Not sure if you'll be able to write, then you'll have to write next year. So very, very important, bring your ID, okay? Note you're not allowed a calculator, so you practice your long division. I failed this one question the first time I wrote because I forgot how to do long division because everyone uses an iPhone or a calculator for that kind of stuff now. So, but you are given scrap pieces of paper to work with, but no calculator, and remember to bring your ID, and yeah. Okay. Okay, so let's take a look at normal glucose metabolism. So usually I'm doing these presentations at a restaurant and we're eating food, and the food's being digested and turned into glucose. So all of us are using glucose right now in our normal body metabolism. So your brain, just by active metabolism, it's using about 5 grams of glucose per hour. And your muscles, if you're inactive, it's using about 8 grams of glucose per hour. So the human body needs a constant supply of energy throughout the day to perform its myriad of complex functions that it performs. However, you're not constantly eating throughout the day. In a lot of healthcare professional jobs, nursing, retail pharmacy, you might have to skip lunch sometimes. So, even so, how is it that your body is constantly being supplied with energy, but you're not eating all the time? And it would be really, really inconvenient if our bodies didn't have some sort of mechanism to take the energy that we eat and store it to be used for later functioning. Our bodies have evolved these complicated mechanisms to store energy when you're eating, and then access it when you're not eating. So let me see here. Yeah, the brain uses glucose. The brain has its preferred source of energy is glucose. It can also use ketones, but its preferred source of energy is glucose. Okay, so let's say you take an average 70-kilogram person without diabetes. Guess how much, if you took out all the blood in my, let's say I'm an average 70 kg person. If you took out all the blood in my body, how much sugar do you think is dissolved in my blood? So I'll give you a second to just take a look at that. Okay, and there's the right answer. So think about it. If you drained out all the blood in my body, there's only 4 grams of glucose dissolved in the blood, less than a teaspoon of table sugar. So, that means our body has very complex mechanisms to keep this very fine balance of sugar. not too low, because then we'll get hypoglycemia and our brain shuts down because the brain runs on glucose, but not too high. There's not a lot of extra sugar in there that to extra sugar stored in our blood. Our blood is not the storage mechanism for glucose. So remember, by the 4 grams, meaning just I'll starve to death in 20 minutes, I'm looking back at this. So if I'm using 5 grams for my brain and then 8 grams for my muscles, that means I'm using 13 grams per hour. So if I only have 4 grams of glucose in my blood and that was my only glucose supply, then yeah, after 20 minutes, I would starve to death. But thankfully, we do have storage mechanisms for glucose. And diabetes is kind of at the core of that. I'll explain in just a more sec. Okay, so this is a really important diagram. I would memorize it for the exam. I think that for most pathophysiology questions, you'll be able to figure it out if you kind of use this diagram. So you can see when you eat, you have large stores of glucose, and then your body produces insulin, and insulin is an anabolic hormone. It builds stuff up for more complicated things. So it takes those nutrients and turns glucose into glycogen, amino acids into proteins, free fatty acids into triglycerides. And so then then that energy is stored in those more complicated molecules. And then when we're starving, like when we have an extra long shift at the hospital or at the pharmacy or things like that, and we can't eat, then our body uses counter-regulatory hormones like glucagon, catecholamines like epinephrine, growth hormone, glucocorticoids to change those complicated mechanisms back into energy that we can use so that we don't have to eat all the time. So because our brain's using energy, our muscles are using energy, and then we can store glycogen in our liver. And actually our muscles are actually a big store of glycogen as well. So just to review, insulin is an anabolic hormone versus catabolic. It's anabolic means to build things up, and it promotes turning simple molecules into more complex storage molecules, whereas counter-regulatory hormones, glucagon being the primary one, does the opposite, turning those complicated molecules back into simple molecules to be used for energy. Okay, so this is usually I do these presentations at LDV Pizza, so that's why I've been enjoying the pizza part. So, so an apologies to anyone who does have diabetes. This is just for my crowd, which is generally people who don't have diabetes. So if you're eating, why aren't your sugars high? Well, you have functional beta cells. Those beta cells are producing insulin. They're stimulating the glucose that's getting into your blood to be transferred to inside your cells to be stored in those complicated molecules. That's how you keep that fine balance of sugar in your system. So how many of your patients have experienced lows? Why does that happen? How did they describe it? So, if you're producing, say, if you have functional beta cells and you're producing insulin, why isn't it that you're having lows? So let's take a look at it. If your body's producing insulin, we all have patients who have gone lows and they describe it as they feel dizzy or shaky or, and very unpleasant is the bottom line. Generally, it's very unpleasant. Our bodies are secreting insulin. I don't have diabetes. My pancreas is secreting insulin. Why aren't I experiencing lows? So take a minute to take a look at this. Endogenous is just produced by the body, basically. So here's the answer. So our body, like a normal functioning pancreas, secreting right into the bloodstream, that insulin only has a half-life of 4 to 6 minutes. So in a person without diabetes, if their sugar starts falling, then their functional pancreas will detect that drop and start responding within a minute of that drop. So after 4 minutes, insulin activity will be down at 50%. That's what a half-life means, the time uh, it takes for something to activity to reduce in half. So after 4 minutes, there's a 50% reduction in insulin activity. Then after 8 minutes, it goes down to 25. And then after 12 minutes, it drops down to 12.5%. So if my sugars, if I started running or something or jogging or something like that, my functional pancreas cells will detect that within a minute or less and just shut down making insulin completely. And then uh, because the insulin activity is dropping so quickly, I don't experience hypoglycemia. That is why people without diabetes they don't experience hypoglycemia to the extent of people on diabetes, like if they're on insulin and stuff like that. If sugars rise, then the pancreas is able to respond with additional insulin in minutes to bring it down. That's why people without diabetes usually don't have hyperglycemia. And this is how the pancreas keeps such a tight control of blood glucose levels. If sugars go up, it can pump out a whole bunch of insulin and within a minute to respond to that. And then if sugars go down, it just stops making insulin completely, and insulin activity falls to zero in a couple of minutes. So that's why people without diabetes don't really experience hyper or hypoglycemia. Now, contrast that with Novo Rapid, which is aspart insulin. It's very, commonly used rapid-acting insulin. It has a half-life of 81 minutes. So, if a patient injects and something, and their dinner's delayed, or if they all of a sudden go for a run or something like that, their body can't adjust that insulin. And so that's why they experience hypoglycemia. And that's why it makes our job kind of challenging too, because we aren't, we're not able to constantly monitor our patients' insulin and make these minute-to-minute adjustments. They have to go on insulin, and they have to take over that, which is hard. Okay, so as per the 2018 diabetes guidelines, diabetes is characterized as A, defective insulin secretion, or 2, defective insulin action, or 3, a combination of both. And that's an important definition to remember. Okay, so give this a look. And I'll give you a second to take a look, and then I'll reveal the answer. Okay, so for type 1 diabetes, we don't really know what causes it quite yet. Type 1 diabetes is a disease of autoimmunity. For some reason, your immune system decides the pancreas is this bad guy, well, specifically the beta cells, and the immune system goes and beats up your pancreas, and then you have no more, without beta cells, you have no insulin. We don't really understand the mechanisms behind that, so for high-dose nicotinamide, that didn't work. You generally don't use metformin in type 1 diabetes. Low-dose insulin injections did work in a small subtype, but overall, they had no effect on reducing the incidence of type 1 diabetes. So in general, in terms of screening and prevention of diabetes, there's really nothing. So beta cell dysfunction in type 1 usually occurs in childhood or adolescence. However, there are cases of people in their 8th decade of life with being diagnosed with type 1 diabetes. It's just most common in childhood or adolescence, but it can occur in any age. The rate of destruction can be quite variable. Usually the younger the person, the faster the destruction goes. So sometimes you can have this honeymoon period where they're on insulin, but not as much as less than what they need when their beta cells are fully destroyed by their immune system. Usually people with type 1 diabetes test positive for one of the various antibodies. Insulin antibodies glutamic decarboxylase, or GAD antibodies, or islet antigen antibodies. These antibodies are related to the immune system, and that's why, as I said before, type 1 diabetes is a disease of autoimmunity. So that's in contrast with type 2 diabetes. So this is beta cell dysfunction in type 1. This is beta cell dysfunction in type 2. For beta cell dysfunction type 2, dysfunction usually happens early, predating hyperglycemia. Some studies suggest that beta cell dysfunction may start, decades before diagnosis, where it's starting to insulin production is starting to lessen or be increased because of insulin resistance, and that eventually wears down the beta cells, and then they start to malfunction. The normal pattern of insulin secretion is disturbed. Beta cell dysfunction is progressive. So how I explain this to patients is it's kind of like retirement. Most people with type 2 diabetes are usually older. And so how I explain it to them, it's like retirement. Everybody wants to retire. Your beta cells are also retiring, Mr. Smith. And so we expect that as you get older, Mr. Smith, that your diabetes will get worse by itself. And it's not your fault if you're dieting correctly and exercising well and it's getting worse. It's not something that you're doing wrong. You shouldn't be blaming yourself, Mr. Smith. It's just you're getting older, your pancreas wants to retire in you, everybody wants to retire, and that's just the nature of diabetes. So if next time, even though you've exercised and ate well, I have to increase your metformin or increase your insulin or put you on a new medication, it could be just the diabetes progressing. It's not necessarily you doing something wrong, Mr. Smith. So that's how I explain it to my patients. It is definitely influenced by genetic factors. It's modifiable by lifestyle factors. That's in contrast to type 1. There's no exercise you can do to prevent type 1 diabetes, and there's no diet you can do to prevent type 1 diabetes. Oh, I put a couple of these in there and I forgot I put them in. So here's the progressive nature of type 2 diabetes. Here, as you can see, years from diagnosis is 0 in the middle there. That just shows that, there's already some beta cell dysfunction even before diagnosis. It progresses after diagnosis. And the majority of people will tend to, if they live long enough, they'll probably have to be on insulin as the beta cells decline in function. And it's important to frame that as well, because a lot of people see insulin as, a failure or an injection, like this terrible injection and stuff like that. So it's important to frame it in the first appointment, saying, beta cell dysfunction is progressive, Mr. Smith. It's just your pancreas retiring on you. It's not your fault. You may in the future require insulin once your pancreas has fully retired. Insulin is a necessary component, normal component of the blood, and your body just needs a certain amount of insulin to keep going. And so, if your pancreas retires, we may have to look at insulin. That's very common in Canadians. It's not something that you've done wrong, Mr. Smith. Okay. So take a look at this, and I'm just going to have a sip of tea. Okay. So here's the answer. So A is incorrect. This is the pattern for people with type 2 diabetes. There's supposed to be a huge burst of insulin as you start eating, that people think what it does is that it preps the muscles to start grabbing all the sugar from your blood. And that doesn't seem to happen for people with type 2 diabetes. Usually that's the first thing that they lose. And then the first kind of type, when you look at their readings, usually it's postprandial sugars that go up high first before fasting. So let me see here. Yeah, it's theorized the large burst of insulin primes the skeletal muscles to start intake of glucose from the bloodstream. And without that short burst of insulin, postprandial sugars tend to rise. B is correct, that is normal insulin secretion. We call that a biphasic insulin secretion, which is normal insulin secretion from a normal pancreas. C is incorrect because there's no third phase of insulin secretion. I just made that up. And D is incorrect. That just doesn't happen in real life. Okay. Huh. Okay, so here's a chart that you can see the differences in normal glucose tolerance, or people without diabetes. So that's what NGT stands for, normal glucose tolerance, and in contrast to type 2 diabetes. You can see that first phase is blunted, and typically you'll see high postprandial sugars with this. Okay, so continuing beta cell dysfunction in type 2 diabetes. Usually insulin is released in a biphasic manner. Again, this happens very quickly in a normal pancreas, starts happening 5 to 7 minutes after you eat. And usually in type 2 diabetes, the first phase is lost. And then eventually, if diabetes goes on for long enough, they will stop secreting insulin at all, and there'll be no insulin secretion, in which case they'll need to go on insulin at that point. Loss of the first phase tends to lead to high postprandial sugars. Okay, so let's take a look at this one. Okay, so here's an answer. And so on the exam, there'll be lots of not questions. Okay, so it's asking for the wrong answer. All of them actually do improve, has been shown to reduce the incidence of type 2 diabetes, but you have to be careful of these opposite questions, which the exam may try to trick you. If you run into one of these kind of like not questions, make sure you circle the not so that you look for the wrong answer instead of the right answer. Okay, insulin resistance. So remember that the definition of diabetes was defective insulin secretion or defective insulin action. Insulin resistance is defective insulin action. This also seems to predate the diagnosis of type 2 diabetes by like 10, 20 years. However, it seems that you need beta cell dysfunction before the frank symptoms of diabetes manifests. This kind of explains why not all morbidly obese people have type 2 diabetes. You know, a morbidly obese person might have huge amounts of insulin resistance, but as long as their pancreas can produce enough insulin to overcome that resistance, then their sugars are still normal. So insulin resistance is often present in people with type 2 diabetes. Usually people with type 2 diabetes are overweight, whereas people with type 1 diabetes are usually more thin. Insulin resistance decreases glucose transport into the muscle cells and makes the liver try to produce more glucose. Skeletal muscle is the principal site of glucose disposal, and resistance exercise can be quite helpful in decreasing insulin resistance in skeletal muscle. Okay, so this is just a chart that shows that if you don't have diabetes, then okay, so from left to right, you can see glucose is increasing. So here's 0 fasting glucose, and then as it goes higher and higher, there's increased glucose. As you can see, when glucose is increasing in the yellow, people who don't have diabetes, their glucose intake goes up, which means those muscles, as your glucose is getting higher, those muscles are grabbing more and more glucose out of the blood and putting it into their cells. But if you look at type 2 diabetes, even as sugar is increasing, that glucose uptake doesn't increase. So that shows that glucose, instead of getting into the muscles where it should be, is still hanging around the blood where it shouldn't be. And you can see the difference between type 2 diabetes and people without diabetes. Okay, so insulin resistance. Which of the following conditions would decrease insulin resistance? So take a look at that and see what the answer you come up with is. Okay, so here's the answer. Ketones increase insulin resistance, which is why typically when you have ketones in the blood, you actually have to take extra insulin to overcome that. Becoming pregnant is a state of insulin resistance. Some of the pregnant hormones involved in pregnancy increase insulin resistance as well. There's more of you, so your body needs to produce more insulin for that. Undergoing dialysis reduces uremia, and uremia causes insulin resistance. So in a lot of my patients, in my dialysis patients, and kidney patients are probably one of the more complicated patients I have. On the day they go on dialysis, sometimes they actually need less insulin. I need to like adjust their insulin on the days on the day they go for dialysis and the days afterwards, because if I don't, they get lows. Because as dialysis removes that urea from their blood, they become more insulin sensitive, and if they have the same dose, then they go low. For D, having high levels of glucose in the blood causes insulin resistance, glucose toxicity, and developing cancer is another state of insulin resistance. Okay, so factors that influence resistance: if you're obese, that goes up. There's certain genetics. Age, insulin resistance goes up. Ketones goes up. Glucose toxicity, pregnancy, uremia, cancer, all make it go up. Okay, so insulin is the key to normal glucose metabolism. And so just remember that insulin is an anabolic hormone, and it's responsible for converting the sugar, the nutrient, the food that we eat into the nutrients that we get from food into storage forms that we can use for later. Okay, so this is Teddy Ryder, and he has type 1 diabetes. He was one of Dr. Banting's first patients. Dr. Banting taught medicine at the University of Toronto and invented insulin treatment. This first image shows him before insulin treatment. And the second image is him after insulin treatment. So as you can see here in this first picture, you can see that Ted's like almost like a skeleton. Look at his wrists, look at his legs, look at his chin. There's like no extra weight there. And so the reason for that is, because of type 1 diabetes, his pancreas isn't producing any insulin. And insulin is responsible for taking all the carbohydrates get broken down in sugar in our digestive system, and storing that as fat and glycogen and stuff like that. So without insulin, your body can't put the nutrients you get from your food into your tissues. So people start starving and wasting away. Type 1 diabetes used to be a death sentence before Dr. Banting invented insulin. So Teddy was started on insulin, and he was, on the second picture, Teddy was started on insulin. He was able to benefit from the food that he ate, and he would grow up and get weight. Here's another picture. As you can see, look at the arms and the legs, just like skeletons. And that's because, and here's another example of people before and after insulin treatment. So all the energy, instead of being stored as fat, glycogen, and proteins for like muscle and fat, it gets sent to the urine instead. And so the body, all that energy just gets wasted. It just gets urinated out. It used to be in medical practice, long time ago before insulin, the test for type 1 diabetes was for the doctor to taste the patient's urine. And if it was sweet, then that was diagnostic for type 1 diabetes. Yeah, that's a class I would definitely want to skip if I was in medical school that day. But as you can see, like if you look at these skinny kids, the reason why they can't gain any weight is because all the food energy that they're eating, instead of getting to their muscles and their fat, it's just ending up in the urine. Without insulin, your body can't make use of any of that energy. And so they got skinnier and skinnier and skinnier. this is a question that won't show up on the exam, but I thought it was interesting. I mentioned that type 1 diabetes was a death sentence before the invention of insulin. So guess what was the average lifespan of a 10-year-old diagnosed with type 1 diabetes? Okay, so the answer is 2.6 years. So if Dr. Benton didn't invent insulin, Teddy would have an average of 2.6 years to live. The 6.3 years is the average lifespan of a 30-year-old diagnosed with type 1 diabetes. And the 9.5 years is if a person at age 50 got diagnosed with type 1 diabetes. So insulin's really important. This is just a picture of the advancements made in insulin. As you can see, Banting and Best, they invented insulin. Then came animal insulin preparations. I think when I was in school, I think people were still using like bovine insulin and stuff. Maybe I'm making myself look old, but I believe that bovine insulin and stuff like that, and porcine insulin was still available. No one used it, but I think it was still available. And of course, using animal insulin in a human, there's quite a lot of variability and stuff like that. Then came NPH insulin, which was synthetic insulin combined with protamine to extend the duration. Then came things like Levemir, Lantus, Detamir, Glargine. Then things like Toujeo and Tresiba and things like that. Those are kind of like the latest advancements. So I just want to quickly look at the BRIGHT study. This was a head-to-head study. Let's take a look at Norman and think about it from Norman's perspective. What kind of insulin, what kind of considerations would you, if you're Norman, what kind of insulin would you like? And as a healthcare professional, what are the kind of important things that we consider when starting insulin? So, once daily dosing is ideal, we want an insulin that's very stable and has less variability, that leads to less hypoglycemia. Coverage, of course, is very important. We want less stability, less hypoglycemia, so there's less pharmacy and hospital visits, less variability in sugars. Smaller dosing volumes is nice. For patients who take high volumes, sometimes they complain about pain and injection because they're taking large volumes of insulin. So sometimes the concentrated insulins can help. And yeah. So the BRIGHT study was a head-to-head trial comparing degludec, which is Tresiba, to Glargine, which is Toujeo. And it was a 24-week multinational trial with about 930 patients who were insulin naive. They were treated with, they could be on oral medications or GLP, even GLP receptor agonists, but there had no prior insulin use. And so they were randomized to Glargine 300. Glargine 300 is Toujeo. That's basically Lantus that is concentrated. Lantus is 100 units per ml, whereas Toujeo is 300 units per ml. That's why they call it Glargine 300 or Glargine 100. So they had a treatment period of 24 weeks and then post-treatment of 7 days. And they were looking at a bunch of stuff, primarily A1C, but also some other measures of hypoglycemia and things like that. So here it shows that Glargine 300 and degludec 100 was basically the same, non-inferior in terms of A1C reduction. Also for fasting glucose, basically the same. For variability, also the same, very similar variability. And so the incidence of anytime hypoglycemia was lower with Glargine 300 in the titration phase. However, in the maintenance phase, it was the same. But during the titration phase, it seemed that glargine 300 had less hypoglycemia. That's right there. Yeah. In the maintenance phase, it was the rate of hypoglycemia was the same. And if you look at nocturnal hypoglycemia, they were also lower with glargine 300 in the titration phase. Right here. So it's important that patients with hypoglycemia are more likely to discontinue their basal insulin. That's why it's important to start low and increase slowly in most cases. For the exam, the most important resource is time. But in real life, your most important resource is your patient's trust in you. And if I put you on this new injection and then you had this terrible reaction where you went low, you felt trembly, got confused, crashed your car, I'm not likely to listen to your advice again. So it's really important that as much as possible, avoid hypoglycemia in your patients. Because in real life, your patient's trust is your most important resource. Let's see here. Yep. Hypoglycemia increases the risk of discontinuation of insulin, risk of hospitalization, and increases healthcare costs in general. So insulin is an anabolic hormone, meaning it builds things up. So in both glargine 300 and degludec, there was similar weight gain. It's not surprising that there was weight gain at all. Insulin is an anabolic hormone. And they had similar safety profiles. Okay, I want to talk about lipohypertrophy. So this guy, those two bumps are from him injecting with probably very long needles into the same place all the time, and then your skin gets angry and develops this fat lump underneath. There's various factors that lead to lipohypertrophies. The FIT guidelines is the best resource to read for that. But those lumps are abnormal, they shouldn't be there. And we want to try to stop that. It is a potential side effect of insulin therapy that we can manage, that we can definitely try to manage. So the reason why people develop lipos, there's a long list of reasons, but repeated injection to the same site and repeated, especially intramuscular injection, can lead into lipos. And so you want to use a needle that's not too long, because if the needle is too long and you inject in the muscle, insulin is supposed to be just injected into the subcutaneous layer where it forms a depot there and then it's slowly absorbed into the bloodstream. It's not supposed to, there's no depot that's supposed to form in the muscle. It's just supposed to be underneath the skin in the subcutaneous tissue. If it gets into the muscle, there's increased absorption, more erraticness, more variability. And more variability leads to more lows. More variability leads to more lows. So we want to avoid intramuscular injection. Yes, intramuscular injection, greater risk of unpredictable insulin absorption, unexplained hypoglycemia, and glycemic variability. And so lipohypertrophy influences glycemic control. Like if you have lipos, they're more likely to have glycemic variability. They're more likely to have unexplained hypoglycemia. And especially if the insulin gets trapped into lipo and doesn't get out, then there's reduction in insulin exposure. So it seems injection technique, the more errors you make with injection technique, that's what IT stands for, I believe, the more it seems that can actually increase your A1C because you're not using your insulin properly. Okay, and that's the end of my presentation. Thanks for your attention. Hope you find it helpful for the CDE exam. And again, if you have any other questions, please check out my website, www.cdestudycourse.com. Hope you enjoyed my presentation. Thank you.